Okay, so welcome again, everybody. Just before we get started this evening, I'd like to acknowledge the traditional owners on the lands on which this webinar is being broadcast tonight and pay our respects to the elders past, present and emerging.
Hi everybody, great you could be here. My name's Kelsey Hegarty and I'm a GP in Clifton Hill, but most of the time I spend being an academic at the University of Melbourne.
Hello, I'm Gene Fader. I'm a GP in Bristol, which is a small city on the Atlantic coast in the UK. And I'm also, like Kelsey, an academic, particularly researching domestic violence.
And hello everybody and welcome. I'm Libby Hindmarsh. I'm a GP and I'm the chair of the RACGP Specific Interest Group with Abuse and Violence Network. And this evening we're going to be looking at these learning objectives. So we're going to try and increase our knowledge about how to recognise early presentations, how to better incorporate an early response, and how to look at it in terms of our whole of practice approach, and to better understand how to work with all members of the family and refer for the safety of victims, survivors and their children. So let's just be a bit clear about there's lots of different names. We've called it family abuse and violence. It's called domestic violence. We often call it intimate partner violence, but it also involves children. Other members of the family may be involved, but we're not going to try and cover that tonight. We'll be trying to talk a bit about victims, perpetrators, and children. And we see this as part of the sort of whole spectrum of violence against women. Now I'm going to hand over to Kelsey to start on the next part.
So everybody, really we want to acknowledge right up front that some of you may have been affected by intimate partner violence. Some of you may have watched the video, and I hope that whatever we say is empathic to your experience. And we know that intimate partner violence, just to make sure we're all talking about the same thing, involves physical and emotional and sexual. Can we put them all up at once, please? Because obviously it's a combination of things involving controlling behaviours. I'd like to also acknowledge that although women are more likely to be injured and more severely hurt, men can be victims as well. And obviously it occurs in same sex. Most of our evidence comes from intimate partner violence against women. If we can have the next slide. The more recent areas that are getting a lot of evidence, and we're drawing tonight a lot from the Safer Families International Conference that we organised last year, where technology facilitated abuse, a form of emotional abuse, where essentially, because it's 24/7, you can use technology. Reproductive coercion, which is where a partner tries to either force pregnancy or force termination, so of a pregnancy. Mental health and substance use coercion, where it's controlling the use, often the mental health drugs or substance drugs that are used by people, and there's a lot of coercion involved in that. And of course, financial abuse is becoming quite prevalent. So if we move on to the next slide, we've got another question, because we just want to get a sense of what sort of training that you've had. So can we have the question, please? And we might pause once we do get the result of that to get some sense of it. So if you can try and answer the question now, and then we'll look at the results. Because some of you may be extraordinarily experienced and we can work out how to pitch what we're going to say to you. So if everybody's answered, can we please have a look at the results? Emma, how are we going?
Just closing the poll now. We've had 74% of people respond.
Great. So small numbers of you, 60% of you had no training. That's a dreadful, isn't it? Do you know that doctors are the highest people told after friends and family? So, you know, and a small percentage of you have had a lot of hours. But look, that's how it is. We don't get trained in our medical courses. Okay, we'll go back to the next slide. Thanks. So glad you could be with us. So if we look at what our role is, we're definitely in the secondary prevention, which is around, we want to identify it, we want to care for any health problems associated, long-term care, especially mental health troubles and alcohol and substance use, and refer as necessary. So next slide, please. And it's really common, partner violence in Australia, in our patients attending and in some work of a colleague of ours from Safer Families Centre of Research Excellence. 1 in 3 first-time mothers experience partner violence before their child turns 4, and it can escalate in pregnancy and postpartum. And it's certainly very common in Aboriginal and Torres Strait Islander women, and more recently, Australian Institute of Health and Welfare showed us that young women were at high risk. And of course, we know that adult domestic partner violence has long-term consequences for children. So next slide, please. Can we just put all of these up, please, Emma? Because the physical, psychological trauma and fear and control, I think that that's a really good way for us to think about it. And I'd like you to have a look at all the boxes underneath and think about how many people that you see on a regular basis present this way. So obviously there's the injury and in the worst cases death, which we read about in the paper, but really it's the mental health presentations, the substance abuse, the sexual and reproductive health presentations, and we've just talked about pregnancy and how it can relate to being quite prevalent then and having low birth weight and prematurity and miscarriage. But we also are starting to look at the links with cardiovascular disease and hypertension, with the long-term chronic stress of being in a relationship where partner violence is happening, and also chronic symptoms of irritable bowel or chronic pain. I think that might sum up all of your patients that you see. So let's move on to the next one, where we're just trying to highlight tonight as well the high levels that can happen during pregnancy. He hit me in the belly and made me miscarry twins. I went to the hospital with heavy bleeding and they cleaned me up. And for those who don't know, there's a special item number for antenatal care if you screen for domestic violence and mental health issues. Okay, next slide, please. So what stops you asking about family abuse and violence? We're just going to put the poll up because we know that only about 10% of health practitioners actually ask. So you're in good company if you haven't asked much. And I certainly didn't before I started researching this area. So if you can answer this question, that'd be great. And we'll try and get a sense of what does stop us asking about it. I think that we all of these things can certainly be the reason, but let's see what the most common is. Can we close the poll, Emma?
Yeah, we're just on about 50%. I'll just give another couple of seconds, get more in.
Oh, we'll get a sense from
There we go. There we go. All
right. Okay, so what we've got is the commonest. So we obviously lack of time is a common one, lack of skills, and the fear of offending the patient. So what we do know from some work that we've done is that we are very unlikely to offend a patient by asking. The vast majority, like it's something around 90% who both abused and non-abused women are not in any way discomforted by being asked about domestic violence. And it's really only a very small percentage who are concerned about it. So I think that the message should be that this is very acceptable to women to be asked about it. Okay, next slide, please. So then we come to the thing about how to ask about it. And I'm just putting this up, even though this is a Victorian work that we're doing. We suggest that you ask by funneling from violence is very common in the home. And we've recently tested a new screening tool in the Royal Women's Hospital here in Melbourne, and it's ACTS. So it's easy to remember about Has anyone in your family or your partner done something that made you or your children feel unsafe or afraid? Have they controlled your day-to-day activities? Have they threatened to hurt you in any way? And have they hit, slapped, kicked, or otherwise physically hurt? Now, we're not suggesting that you screen everybody. Certainly, it's been brought in Victoria for antenatal care, but it gives you some questions to think about. And then asking the person about their own assessment of safety. Do they have any immediate concerns about the safety, and do they feel safe when they leave here today, and who they would engage with? And mixing this in with mental health and other alcohol and drugs, I find it quite easy to do. The next slide. But then what do you do when people say yes? And I'm just going to show you these questions because some people say to me, how would I know someone was at very high risk? And this is from risk indicators that are associated with severity and death. And certainly is if the perpetrator is unemployed, if the physical violence increased in severity or frequency, and also a whole list of if they've recently the perpetrator's threatened suicide, using drugs, has been following and repeatedly harassing the person, been obsessively jealous, threatened to use a weapon against them, assaulted when pregnant, choked, forced to have sex. Sexual assault's very highly associated with risk, and obviously threats to kill. Now, you mightn't feel comfortable asking all of those, but often I just ask some of them, and that helps me get in the swing of it. And then I often ask, do you think that they could be, is it possible they could kill or seriously harm you? And of course, we need to be concerned about children. Recent separation is certainly an indicator, because it's often as the woman's moving away that there's a lot of danger. But let's move on to the next one, where I'm going to hand back to Libby to tell us what to do when they say yes.
So the question is, how are we going to incorporate this into our primary care? So at the conference that we had in November, the Claudia Garcia Marino from the World Health Organization came up with lives, and that's on the next slide. And lives is just a way of thinking about what we should be doing when we're sort of starting to try and ask people about what's going on. So we need to L for listen closely, I for inquire about their needs and concerns, V for validating their experience. It's amazing what happens when you believe somebody. Then the E is to enhance their safety, and S is to support them and to connect with additional services. And it's really, really important that we not do any harm and that we respect people's wishes. So then on the right-hand side, you'll see just these little things. You watch that you're giving them undivided attention with your eyes, you're listening to their concern with your ears, and you're showing caring and respect. Thank you. Okay, so the role of general practice in keeping families safe involves recognise. So we need to identify when a patient or family member is exposed to harm, and that means we need to ask. And then having asked, we need to, and they say yes, then we need to think about talking to them about safety. And we need to be thinking about how our practice is safe for our patients, for the GPs, for the other staff, and we need to be thinking carefully about boundaries and confidentiality. And at the appropriate time, we might need to refer and link them with other services. So people often talk about, so what's this safety plan you're talking about? So a safety plan can be as simple as where to go to be safe and who to contact. And then and it includes things like emergency numbers, a safe place to go and how to get there, who will support you, will you have some money or credit available, and have you got those valuables, those important documents that you might need, especially if you're leaving. So now I'd like to hand you over to Jean Feder. And Jean also presented at the conference in November. And Jean's going to summarise some of the issues and tell you about the work he's doing in the UK. Thanks, Jean.
Thanks, Libby. So we, well, more than a decade ago now, time flies, really wanted to try and understand what women themselves who were experiencing abuse wanted from and expected from healthcare professionals, particularly doctors. And it turned out, even it was 14 years ago that we began doing the review, there were 25 in-depth qualitative research papers which brought out the voice of patients, of women patients. And there was a very clear narrative that came together when we looked at these papers around what they would really want. I mean, first of all, just to echo what Kelsey said, doctors are the second most common go-to people and the most common professionals that survivors of domestic violence or intimate partner violence want to turn to. It doesn't mean they always get the response that they would want, but we are still the trusted professionals. What we've done in the way we looked at this was we took the structure of the consultation and the structure of the presentation of symptoms right through to the clinical response. So if you look at the first box there, what women are saying, and these are survivors, are saying that they want us to be alert to the signs of domestic violence, and they want us to raise the issue. They want to be asked. They would like some recognition that within the practice, it's appropriate to talk about partner violence, and one can do that through posters or other information, say on the practice website. And they want to have some confidence that anything that's disclosed within the consultation is going to remain confidential, which is, of course, a key mantra for clinical practice, for general practice, that what happens in the consultation stays within the consultation unless there's a specific safeguarding issue. The second part of the trajectory is how we respond. That first minute of how you respond when a woman discloses is essential to get right. It's not difficult for trained clinicians to get that right, because we do that all the time when we get difficult information from patients. But for instance, saying something like, "Oh, what did you say to him that made him do that to you?" Or, "Gosh, why don't you, this is terrible, why don't you just leave?" These type of responses are really unhelpful, and our patients will then close down and think, well, that's the last time I'm going to disclose anything to this doctor, or perhaps to any doctor. So a non-judgmental validation without pushing the patient to do more other than initially disclosing is key, and taking the time. I mean, time is precious in general practice in the UK as in Australia, but taking that time to listen, particularly in the first disclosure, is key. And then some addressing of safety concerns, not doing a comprehensive risk assessment, but the kind of pragmatic response that Libby outlined. And then the key aspects of the ongoing relationship we have with survivors is understanding that this is a chronic problem in many patients and does not necessarily require an immediate fix-it type response. And, this is familiar to us as GPs, because this is the attitude and the approach we take with other chronic conditions like diabetes, with recurrent depression. We've learned how to do this sort of holding, but also some form of expert intervention to support the patient. And that expert intervention may lie outside the practice. Respecting the woman's wishes and allowing her to have some control over what happens next is crucial, because many of these survivors are living in a highly coerced, controlling home, and we don't want to reflect and replicate that in our relationship with patients who are experiencing abuse by coercing them to do something. So it's really about trying to respect their agency. So those are the key messages that come from women themselves. Next slide. So the idea of a whole practice response is, again, in some fundamental way, no different from a whole practice response to diabetes or secondary prevention of coronary artery disease. It's something about the clinical policy being taken on at the level of the practice and requiring support between clinicians, and that's nurses as well as doctors. In the UK, we've developed now it's a national training program to train whole practices in applying some of these key lessons about what's effective in responding to survivors. And our contention is that one does need practice level training. This webinar is important, but it doesn't necessarily, or it can't replace some form, we believe, of face-to-face training in working out how a practice is going to respond and getting the policies in place. And next slide. So these are some of the steps. I mean, what we're recommending is a meeting in the practice to look at policy and making a commitment to this being an issue. Crucially, what we found in the UK is that doctors, and for that matter nurses, are not going to ask about abuse unless they feel that there is some kind of other support that they can refer the patient to or signpost the patient to. We can't do all this on our own. And just like healthcare is not going to provide the solution to domestic violence or family abuse nationally, and just has to play a part. By the same token, individual doctors and nurses can just play a part and need to really link up to these other services which can support our patients if they want to access those services. So there's some very practical things on this slide, some policy about how you make visible the practice's commitment to domestic violence, how you will make sure that confidentiality is retained. I mean, confidentiality is crucial here, because if a woman discloses and her partner finds out that she's disclosed, then that can cause for the abuse to increase and in fact for her to be killed. I mean, the actual risk here is substantial. Not with all patients. I mean, there's a spectrum of severity and risk, but that's the potential of violence to actually cause serious harm or death. And then the final bullet point here is that this is something that requires everybody in the practice, from the front desk right back to admin staff, to be aware of the issues and to have some form of training. And next slide. I'm going to just complete my part by talking about our response to perpetrators. Perpetrators of domestic violence are our patients too. They belong to us as our patients. How do we respond to them? And so we'll just do a quick poll here about how often have you ever identified a male patient who uses violence? Okay, so a really interesting range. And what it shows is actually the majority of you have become aware of, either through disclosure or through prompting, of a patient who is actually using violence. So they are visible to you. And one of the reasons we've begun focusing on this in our research is because there's very little evidence about how we as healthcare professionals, particularly GPs, should be responding to perpetrators. Part of this issue is actually also how to respond to male victims of domestic violence. And they are an invisible group. And there often is an overlap. I mean, sometimes perpetrators do present themselves as victims. Male victims are sometimes very reluctant to disclose. There's a sort of double stigma about being a victim if you're a bloke. So this is a more complicated issue. We feel we have good evidence about how to ask and how to respond to women survivors. We have less evidence about how to identify and respond to perpetrators or to male victims. So here's some key points, I guess, about how we should do that. So the first is to think about whether it's even possible. So if a man presents with depression and anxiety or anger problems, is there, what's going on at home? What's the relationship like with their partner? Is it possible that they're using violence in that relationship? Some of the questioning is similar to the questioning we ask around around experiencing violence, and often there may be an ambiguity in the response that we get. I don't believe that as doctors or nurses we can necessarily distinguish being a perpetrator or a victim if you have a man who's worried about their behavior and worried about what's happening at home. I think part of that work really has to lie with some of the specialist family abuse or domestic violence agencies. But the main thing is to provide a place where a man can begin to talk about it, particularly in relation to their mental health, which is how this issue may present. So asking about physical violence, asking if they're worried about their behavior, asking about whether they think that their children, the children in the home are being affected by what's going on. And this key issue about showing your respect for the patient, which is again at the core of general practice, but not condoning or justifying their behavior. Now, in the UK and in Australia, there are perpetrator groups or behavior change groups. Knowing that these exist, finding a way of referring to them, if that's what a man wants, I think is a crucial way of making it worth our while to see the perpetrator there as our patient. And next slide. I think I'm going to hand back to Libby here to talk about children, which is another area that needs to be understood, how we respond to children who are exposed to domestic violence.
Yep. So we've talked a little bit about victims and a little bit about perpetrators, but we mustn't forget the children. And we need to be asking about the children, and we need to be thinking about their safety. So ways of keeping children safe. So we need to accept that all children who are living in a situation where there is family violence are being affected in some way by this situation. So that's what the evidence says. So the first thing to think about is to work with the victims to keep them safe, and the best way of keeping the children safe is when the victims are safe and are looking after the safety of the children. So, and acknowledging that the children will be affected and providing specific care for them. So children who've been involved in family violence, when they're in a safe place, will also benefit, many of them, from specific children's services to help them to deal with what's going on. Now, some of the children that we see will be at risk of significant harm, and we feel that the non-violent parent isn't able to look after them or is colluding with the perpetrator, as occurs in some situations. So we may need some advice from the child wellbeing unit in your state, and certainly there may be the need to mandatory report. So, as doctors are mandatory reporters, we'll need to make a report to the Children's Protective Services, whatever that's called in your state. And we need to do that if we think there's on reasonable grounds that the child or the young person is likely to suffer significant harm as a result of physical injury or sexual abuse. and that the child's parents have not protected them or are unlikely to protect the child from harm. So it's different from state to state, and that specific information is in the chapter in the White Book in Abuse and Violence, and that gives you the information for your own state. But no doubt you've looked at that before. So Kelsey's going to talk about this. Have we lost you, Kels? We want you to think about
I've got
what.
to unmute. That's what the problem was.
Oh, you're muted.
Yeah.
Right.
So
Well,
I really encourage you to start to write some questions. I've been looking at the questions and the challenges that some of you are having, and interestingly, Libby and Jean, the main areas has been around mandatory reporting and what the obligation is on people. And I think this is a difficult area for me. In Victoria, it's fairly straightforward because exposure to adult domestic violence is not in our child abuse definition, because it's physical and sexual violence that causes significant harm, and there's a non-protective, neither parent is protective. But I think that if you think about how common domestic violence is, so we've been saying that somewhere around, 1 in 4 of your patients are going to have experienced this. And so people are feeling like they want to protect the children from this adult domestic violence. And so I've certainly had people say to me that they want to report everybody who's exposed to domestic violence, and it really is untenable. We have to be looking at the ones where there's going to be significant harm. So I wonder, while people are writing their questions, whether Libby or Jean, you want to make further comments, because for Jean it's a strange thing, because I know in the UK you don't have mandatory reporting of child abuse. So Jean, do you want to go first?
When you say we have mandatory reporting for child abuse, and of course a form of child maltreatment is exposure to domestic violence. So there is that. So the issue for us is whether the impact of what's happening in a home crosses a certain threshold for child maltreatment. I don't mean direct child maltreatment. I mean being exposed to your parents or significant others in the family perpetrating domestic violence. So we do have a dilemma there. I mean, the idea of mandatory reporting for all domestic violence would be a very sensible suggestion if there was any evidence that the response, the criminal justice response, was effective. But actually, we don't have that evidence. So, on the grounds of first do no harm, mandatory reporting falls at that hurdle. And I think, so I'm very keen that we don't move towards mandatory reporting. There are states in the United States that have implemented it, like California, and one of the findings after that was that the disclosure within healthcare settings went down because women were scared that if they disclosed they were experiencing abuse, that there would be an automatic reporting to the police. So I think that the danger for me of mandatory reporting is that it even more takes control away from the survivor. I think in relation to children and vulnerable adults, say with learning difficulties, I think it's crucial that we do have a system and a threshold for reporting. I'm still wary about how effective, say the Children's Services response to that is, and where the evidence is for that being effective and safe. But I think with vulnerable adults and with children, we do have a duty of care, kind of in loco parentis type relationship, where we should be reporting.
And Libby, we've had two further questions about this. One is where significant harm. So how do we assess significant harm in this when we're trying to work out whether to report?
I think that that depends on what's happening with the child, and certainly with some children in these families, they're acting out, they're getting into trouble at school, they're, you know, a number of things are happening to them, and when those things are happening, then, you know, that's a red flag to us that something needs to, you know, be done to support these children.
Yes, that's
Yes.
right. And someone else has commented that it's frustrating that sometimes we don't get an effective response. And yeah, and I've just noticed, Bill Lilly, welcome, moving to a paradigm of resilience from a paradigm of risk in our collective understanding is slow and frustrating. And I completely agree with you that we're so worried about identifying the risk when in fact all these children need assistance from a strength and resilience based paradigm of trying to get them some assistance.
Kelsey, can I just check something? I've tried to answer a couple of the questions just in writing. So I answered a question about why it's not a good idea to ask a woman why she doesn't leave in the first response. Is that visible to everybody, or have I not somehow managed to do that?
If you sent it to all down the bottom, I've answered to everybody as well.
Yes.
So yeah, I'd already answered that. Yeah.
Can I say, somebody's asking about people who don't have any Medicare. None of the domestic violence services will be asking you if you're got Medicare. So there are those services will be there, and in terms of services to asylum seekers and people without Medicare, then there are some services. For example, in Sydney, there's the asylum seeker service, and there they can get some healthcare provided free of charge. And certainly there are GPs who are providing care to asylum seekers and people without Medicare on just out of their goodwill. So there are.
So, yeah, I'm just going to move us on because I can see quite a number of questions, and I'm going to coordinate them all. So one of them is around screening and when's the right and appropriate place to screen. And both Jean Feder and I have been involved in this Cochrane screening reviews, Felicity, and really the evidence would be that we shouldn't screen all our patients, you know, just anybody who's coming in for any reason whatsoever, except if they've got indicators. And as I talked about it towards the beginning, there are a lot of indicators that we should be asking. Anybody with a mental health issue should be asked. Anybody with chronic pain, anybody with injuries, obviously, but essentially almost every psychosocial type presentation often has underlying it the domestic violence. But when we talk about screening, we're really talking about screening every person who comes in, and that's probably sufficient in antenatal care. And Jean, do you want to just make a very quick comment about that?
Yeah, that's what I just wrote in a response, but I don't seem to find a way of making these responses visible. That's exactly the framework we're using in the UK. We call it clinical inquiry. So you're picking up presenting complaints or conditions which we know are associated with violence, and then asking specifically as part of a clinical history. I think the evidence around screening is still very poor, although in the UK we do have a screening system within antenatal care.
Yeah, it's the same mostly here. So the next question was, how do we define financial abuse? And I think that when you look at people controlling each other's finances, often it can seem like there is one person in the partner who does actually take responsibility for paying the bills and doing those sorts of things. We're not talking about that. It's really where one partner does not have access to the equal resources. And there's been quite a lot of work in the UK about this. So if the person who asked that question would like to send me an email, I can talk about that. Libby or Jean, do you want to talk about financial abuse at all?
Well, it's just really unequal. It's really interesting stories people tell you. You know, like I'm given this much money to do the shopping, and I have to account for it all. And when you just start to talk to people, you know, about what's going on about the money in the family, you get some very interesting answers where there is no equality.
Yeah. So another area someone's raised is they found that sometimes the person seems reluctant to disclose or engage. And I think that we have to realise that it's like readiness to talk about it. You know, it may be that on that particular day they don't want to answer the question. Maybe they don't feel comfortable with you. And that's okay. And sometimes they do disclose to you and then they don't come back when you ask them to come back. And of course, that's worrying. But sometimes people just need to take some time. You're still flagging to them that this is an area of interest for you. And I think that that's, you know, really important. And if, you know, one of the questions is if a woman requests for immediate safe place or shelter, then what, you know, should you do? In each state, there is a crisis place that can help you to get a woman to a shelter. I find the crisis the easiest. You know, I think that there's lots of service to when a woman wants to leave and needs to be helped that day. It's not always that she can be moved to, you know, housing that day, but there are definite services for that sort of crisis thing. I think referring back to Jean's work about how it's like a chronic condition, often we are the sounding board for them. Would you like to add more about that, Jean?
Well, only, I guess, to chime in with the underlying principle, which is respect for a patient's agency and autonomy, even though she is in a coercive situation. And I think that, you know, we mustn't further infantilize patients who are not vulnerable in the sort of legal sense, who don't have learning difficulties, who aren't children. And it's hanging on to that idea that we want to support our patients in making decisions that will affect their lives. And I think asking again, reminding a patient in a future consultation about what she has disclosed, even though she doesn't want to do anything more about it, is part of our job. But hanging on to the principle of trying to empower and support our patients is, I think, at the heart of this.
So quite a number
it's about hanging in there. It's about hanging in there.
Okay. So I think there's two more themes coming through the questions. There's still questions about, you know, someone says, well, if it's that common and it causes that much ill health and we have questions that seem acceptable, why wouldn't we ask? And look, in some ways that's true. I think the reason to meet screening criteria, you actually have to know that you can make a difference. And both Jean and I have tested interventions in general practice, and they have had some positive response. Jean's with referral to services and mine with depressive symptoms and discussing safety. So I think there are emerging evidence around it, but when we've done the systematic reviews, it's just we're not confident enough that we can make a difference by asking every single person. But if you have a high threshold for asking routine questions with people who are presenting, the clinical inquiry, the routine inquiry, you will be asking a lot of people.
I think you mean low threshold.
Oh yes, sorry, I did mean low.
And I think, and I completely, you know, am at one with Kelsey on this. I think there is a potential. I mean, the question was, you know, is there a downside to screening? Why not? I think the one potential downside, which we have actually seen in antenatal care here in the UK, is that if it becomes part of a panel of screening questions, it can often be asked with without any real intent to hear the response. And so, ironically, this comes from colleagues, young women colleagues who've become pregnant and have got antenatal care, received antenatal care in the UK, who were then asked by the midwife, everything's all right at home, isn't it? Tick. And that was the screening question. And I think what I retreat back into is a sort of strong view that if we ask, we need to ask as if we want to know the answer. And that is that is different from a routine screening question, which comes in a whole battery of questions. So I agree with Kelsey. Our threshold is low. We may be asking the majority of our women patients, because many of them will be presenting with, say, mental health problems, but it's never, if it's a routinely asked screen, that is unlikely to produce the kind of response that a meaningful question within the clinical history would have. I mean, I don't have firm evidence on that, but I think that's the way the evidence is stacking up. You need to ask as if you want to know the answer.
Yeah, it's the quality, not the quantity.
Yeah.
And I really like what Wei Mei is saying here. I wonder if focusing on how to apply strengths-based assessment and a greater awareness of services and options available may help empower GPs in consultations involving domestic violence. And a lot of people are asking about services. What are the services in New South Wales? What are the services in Western Australia, etc.? And the answer is, like with a lot of our other areas, particularly mental health and alcohol and drug, affordable services in this area, even in Victoria, which are expanding as a result of the Royal Commission, there is still not going to be accessible, affordable, easy services for many people who are survivors or men who use violence, or for children. But when I say that, I mean that, of course, we're expanding them and they're becoming more available and it's better. But in the end, like with many things that we as GPs need to deal with, we don't have an exact referral option. But I still think we can have a strength-based assessment and work with our patients, as we do with many, many other conditions that are chronic, where we see them on a regular basis, and we shouldn't underestimate the power of us listening and being supportive. Anyway, you can't answer me. That's part of the trouble with this web.
Yes.
But
The other thing,
yeah.
I think we should maybe quickly go to the resources that we've got to share with people, so that they've got some resources. And now we're going to send these out to you in an email, so you don't feel you have to copy them right down at the moment. So this is some resources for extra training for practitioners. The next one is some resources for families, and 1-800-RESPECT is a national number. It's 24 hours a day, and they are very happy to talk with health providers. So you can ring and talk to them about an issue that you've got to see what information and support you can get for that. Then there's some further resources for Aboriginal and Torres Strait Islanders. There's the White Book, which we hope you all know about and are finding very helpful, and which we are hoping to update in the next 12 to 18 months. And then there are some resources for men. Now, these are all fairly national resources. The way to find out about what's going on in your area is either to look at your health pathways for your PHN, or it's to ring one of your state domestic violence services and ask them what services there are in your area, and they can be really, really helpful with telling you about that. Okay, back to you, Kels.
Okay, so we really have tried to cover quite a number of areas today. And obviously we've tried to cover whole of practice, and we've tried to cover whole of family, which is really difficult to cover in 45, 50 minutes. But I hope that we've suggested to you, can I have the next slide? That we have covered the ideas of how to recognise presentation early, how to respond using a whole of practice approach, and we're doing some current training, and Jean's done a lot of it in the UK, where we do get the reception staff and the practice managers in to train with the clinicians, because it does involve a lot of issues that are broader than just the doctor and patient or nurse and patient. And how that we can work with all members of the family. And, you know, really we're not suggesting you talk to all members of the family at once, but we do see all members of the family. And how do we keep the safety of victims, survivors and their children, you know, high on the agenda. So I'm going to turn, Emma, how much time have we got left before you need to wrap up? Have we got a few minutes for Jean and Emma for Jean and Libby to make some final comments?
We do. We've about 5 minutes left.
Okay, well, there, I'm going to time you 2.5 minutes each. Off you go. Who's going first? Jean.
Okay. Well, really just to say that I think responding to our patients who are experiencing domestic violence is part of and needs to become a clear part of our core business as GPs. There is reasonable evidence that us responding to them, asking and responding, does bring benefit to our patients, particularly if they get additional support from specialist services. And, you know, my hope is that, you know, in 10 years' time, we won't need a special webinar, because medical students and, you know, registrars training to be GPs will have had this training, and that it'll become part of normal care.
Libby. Are you muted, Libby? Yes.
We really wanted to bring you some of the outcomes of the conference. It was a wonderful conference in Melbourne on health and domestic violence, and so these are the really core things about what people were talking about us being able to ask, about us being able to be very validating of people's experience, of believing them, listening to them, and being non-judgmental. And so we wanted to come tonight and convey some of those ideas and things to you, and I hope that you found that to be helpful and encouraging, because it's not an easy space to be working in, but it is a really important space. And as Jean said, we as primary care people cannot be responsible for the whole of this in practice in our community, but we do need to do our part of it well. And so I would really encourage you to do your part of it well.
And my final point is to go back to the fact that we need to take care of ourselves and self-care, but also we need to use the college resources, that there is support for us in terms of counselling or other things if we need help, and particularly in view of what we're, you know, saw in the video at the beginning, if you managed to get onto it, is about some people have their own experience of this issue. And you know, what the GP on that video was suggesting to us was that prevention, you know, that actually starting in schools would be the place to be, where we would have less people that we would need to see. So I think I'll hand back to Emma now to close it off.
Thank you. Thank you. So thank you everybody for joining us this evening. We hope you found that useful.